Hello, everyone, and welcome to the 2020 Conference on Metastatic Breast Cancer. Thank you for joining us for today's breakout session, Treating Bone Mets. My name is Erin Allen Hansen, and I am the Director of Outreach at Living Beyond Breast Cancer. I'm excited to serve as your moderator, and I'm honored to introduce today's speaker and longtime friend of LBBC, Dr. Adam Brufsky. Dr. Brufsky is the professor, is a co-director of the Comprehensive Breast Center at the University of Pittsburgh Medical Center, Hillman Cancer Center. He has spoken with us for many, many times in the past, and we're so excited to have him here today. We are so grateful to be able to provide what I know will be an informative session for you. And we are in challenging times, and your support is more important than ever. So if you are able to send a donation to LBBC, you can do so at lbbc.org. The donate button is on the top navigation bar. Also, if you are on Instagram, we encourage you to follow us and invite your friends to follow Living Beyond Breast Cancer. We are so close to the 10,000 follower mark, which is a really important milestone for us. We will be welcoming your questions and comments, so please look at the bottom of your screen and say hello to us in chat. Sharon has already welcomed us today. Let us know where you're joining from and how you're doing today. There's also the Q&A feature, and that's the best place to ask questions. We will be having Dr. Brufsky answer the questions in the second part of his presentation over our time together. So just as a quick reminder, please frame your questions in a general manner. Dr. Brufsky is unable to give specific medical advice or personal consultation. So now let me welcome Dr. Adam Brufsky and have him take over the presentation.
So I do a lot of breast cancer. I've done it for probably about 25 years. And, you know, I could talk on any topic really with metastatic breast cancer. And I think in the question and answer session, which will be probably about 40 minutes or so after I go through a little bit about bone health. You know, we can talk a little bit about it. We're really only going to talk about prevention of bone complications. There's a lot of really interesting stuff about prevention of bone loss that we could talk about, prevention of recurrence of breast cancer we could talk about. It's all kind of interesting and it's all kind of related. But in the interest of time, they only asked me to talk for about 20, 25 minutes. And I'll just talk mostly about, I think, what's really important. I mean, all of them are important to women with metastatic breast cancer because they all speak to the same mechanism. But I think it's important to talk about bone complications and kind of what we do about them and kind of where to go from there. So with that, let me see if this works. Okay. So the first thing really is prevention of skeletal-related events. And what is a skeletal-related event? I think a lot of you know this, but it is not so much a new metastasis in your bone, but rather a complication from an existing one. So in other words, you know, you have more bone pain, so you have to go up on your pain medicine. Or you need radiation to a new part of your bone. Or you fracture something and need surgery to bone. Those are what we consider skeletal-related events. I think we used to have hypercalcemia, but because we use these bone-targeting agents so much, the incidence of malignant hypercalcemia in women with metastatic breast cancer, really, since I've been practicing, which is, again, about 25 years, has gone down dramatically. And so we still consider it a skeletal-related event, but it's not one that's been there, you know, one as frequent as it used to be. So in other words, I'm going to go through these slides. They're a little bit complicated. I'll try to explain them, but you know, a lot of these I give to actual physicians around the country when I speak on this sort of thing. But again, the whole idea, you have bone metastases that are called osteolytic, and what that means is that you have this little osteoclast down here, and it's a cell, a specialized cell of the bone that likes to chew bone up. And, you know, that's what it does. In normal osteoporosis, as you get older, these cells tend to get a little bit unregulated, and they actually tend to chew bone up more. And that's the whole idea behind age-related osteoporosis in older women. And what they do is they kind of secrete all these kind of things like hyaluronic acid and other things, and that dissolves the collagen of bone down here. Bone, all it really is a protein called collagen with a lot of calcium bound to it, something called hydroxyapatite. And the whole idea is the osteoclast secretes all these enzymes that chew it up. But anyway, the bottom line here is that there's all these things that the tumor makes. You know, it makes something called parathyroid-related hormone, all these interleukins, something called tumor necrosis factor, something called MCSF. And what they do is they stimulate these osteoclasts to chew bone up. And what happens is that the osteoclast then turns around and actually makes a lot of stuff that stimulates the cancer. So like these things like transforming growth factor beta, all these other growth factors like insulin-like growth factor, fibroblast growth factor, etc. And it's kind of what we call the vicious cycle. So the whole idea is to try to break the vicious cycle. That's what we try to do with bisphosphonates and with actually rank ligand inhibitors, we're going to talk about it in a minute as well. That's kind of what we do. And that's the whole kind of, when you think about trying to reduce the complications from bone mets, what you're really trying to do is stop this osteoclast from chewing up the bone around the cancer and making it weak. And some of us believe we actually treat the cancer as well by turning off the osteoclast, at least in the bone part of your cancer, trying to slow down its growth as well. What I always like to tell people, it's sealing up the bone around the cancer so it can't grow anymore. So anyway, this is kind of what happens here. You know, bisphosphonates generally, the way they are, and rank ligand inhibitors is a little bit different, but bisphosphonates, what they do is they're concentrated under the bone. And because they have the same thing and kind of look like almost like hydroxyapatite, and they go to the bone and the osteoclast chews them up. And then they're kind of chewed up and released inside of it, and they kind of do a lot of things inside the osteoclast that are kind of complicated. I think for the longest period of time, we didn't really know what it did. I think now there's a lot of emerging research that a lot of guys like me are going to exploit, that we kind of actually, I think to some degree what it really does. It's kind of a fascinating thing that they do, and I'll get into it a little bit, but it's kind of interesting how they actually do this, but that's the whole idea behind it. And then again, they inhibit the activity, what was called programmed cell death in the osteoclast, we believe. So the osteoclasts kind of die off a little bit and you have fewer of them. Now remember, you still have to make new bones. These are osteoblasts that are sitting there, and they basically actually are a little bit stimulated by the bisphosphonate, because it turns off the osteoclast and stimulates these cells here, the osteoblasts, to make new bone. So it's kind of a crude way of explaining it, but that in kind of a nutshell is what's happening. And so these are the bisphosphonates. They were originally designed, believe it or not, by the Hesch Corporation in Germany. And this was probably about 120, 130 years ago. You know, we in Western Pennsylvania, I know there are people around the country listening to this, but we in Western Pennsylvania, you know, were one of the first oil finds, you know, in the world. And in Titusville and Oil City, it's about 2 hours north of Pittsburgh. And one thing they realized pretty quickly when they were drilling for oil is that the oil would all get clogged. It would be all these like kind of organic compounds that get clogged in the drill, in the wells, and they have to clean them out. And so basically, atigranate was designed as a pipe cleaner. That's how it officially became designed. And then, you know, over time, they had these first generation ones here, the second generation ones that have this nitrogenous group on it, and then finally, these ones here that have this organic group on it, this kind of, you know, benzene-like ring with a nitrogen in it. And it's interesting, residronate actually was designed by Procter & Gamble as laundry detergent. And actually was remarketed as Actonel in the probably about 40 years ago, 30 years ago. And it's a very powerful oral bisphosphonate. But zoledronic acid is an intravenous one that we use a lot right now. And really, when you look at these, the first generation ones really weren't that potent. So the idea behind this graph is how much can it inhibit bone resorption, like in an animal model. And again, this just shows you here how potent it is in a rat. Atigranate, the first generation isn't that much. These middle ones like pamidronate and alendronate are okay, but then you get to ibanginate and zoledronic acid, and they're the most potent of all the bisphosphonates. So, we have all these drugs here, but we really want something that inhibits the osteoclast, inhibits bone resorption quite a bit. And what does it do? Again, this is kind of complicated, but it's kind of fascinating because it's really going to eventually, I think, speak to what's actually happening inside the osteoclast that we didn't know for the longest time, but I think we do now, that it inhibits this. There's mevalonate is actually, it's the first, It's the first step in making cholesterol. And what this does is that it inhibits cholesterol biosynthesis, not like statins, although statins do too. It's a later kind of portion of the pathway. And it inhibits this thing called FPP synthase, which actually attaches these fatty groups, these fatty acids, to proteins that have to be inserted into the cell membrane. And if those proteins aren't inserted properly, they don't work very well. And that's kind of basically how it works in the osteoclast. It's a little more complicated than that, and I'll just leave it at that. It's a really fascinating mechanism. But the bottom line is that it's pretty interesting. But for the people who have breast cancer, you know, this is kind of interesting to see how it works. And again, this is kind of what it does. So it kind of blocks that. And again, the higher generation bisphosphonate you have, the more inhibition you get of this enzyme. You see zoledronic acid inhibits completely, residronate, a bit of abanginate, etc. Don't inhibit it that much. So zoledronic acid is really the most powerful one. And so this is kind of like this is a whole, where we do meta-analyses of large numbers of clinical trials, and this is basically zoledronic acid being given to people versus placebo. These are women with metastatic breast cancer, and you can see here this reduces the risk of these skeletal-related events, as I said before, by about 40%. It was significant. Pomidronate by a little bit less, ibandronate by less, as you can see here, but they still do it, but not as much as zoledronic acid. Even oral clodronate, a pill that's not available in the U.S., is called Bonafos, can do it as well. And it really depends on the trials. But the bottom line here is that you can see that the more powerful the bisphosphonate is, the bone-targeted agent in this case, the better it's going to do. And I think that's pretty cool, and I think that this is kind of the science behind what we do. Now, there are other things called rank ligand inhibitors, and again, I'm sorry, I forgot the cartoon. It kind of always gets messed up when I do this presentation. But rank ligand inhibitors, there's one called denosumab. A lot of you know it as Xgeva, and the idea is that it's a subcutaneous injection given every month, and what it does is it binds to a receptor on the osteoclast called the rank receptor, and it inhibits it. So there's something called rank ligand that binds to the rank receptor on osteoclast, and denosumab kind of binds as an antibody that binds to that rank ligand or the rank receptor instead, and blocks the ability of these rank ligands to bind, and as a result, the osteoclasts kind of, again, go into apoptosis and they kind of stop working, and that's the whole idea, to reduce the amount of osteoclasts. And so this is a really interesting trial that Alison Stopek, a friend of mine, a colleague from the University of Arizona, did many years ago, probably about 5 or 6 or 8 years ago, comparing denosumab to zoledronic acid for the prevention of skeletal-related events in breast cancer patients with bone metastases. And what we did in this trial, or what they did in this trial, is they took, I think, about probably close to several hundred patients with bone metastases and breast cancer, gave them either zoledronic acid or a placebo shot, or denosumab and a placebo shot. So it's a placebo-controlled double-blind trial. And in this study, you can see here the time to someone getting a first skeletal-related event was zoledronic acid over 2 years, whereas with denosumab, it wasn't even reached. It was an 18% reduction, which is okay. I mean, I think it's enough, and we debate this all the time with the payers. Is this enough to actually, have the increased cost of denosumab versus zoledronic acid? We've had these debates for quite a while, and it's kind of hard to know. Some payers buy it, some don't. It's very mixed depending on what part of the country you're in. But a lot of payers now, because zoledronic acid is generic, make you use it. But on the other hand, the docs sometimes try to get denosumab for this reason. But the most important thing I want you to note in both areas here is that it took 2 years to get a skeletal-related event, even with Zometa. So what that means is that people are doing pretty well. The amount of bone fracture or new bone pain that people get is less. Now, everybody's going to get bone pain of some sort or another, I'm guessing. With metastatic breast cancer, we can't prevent everything. But on the other hand, this is in contrast to the days when we didn't have these sort of drugs. So I think it's done quite a bit for people since we've been using them. What's called the skeletal morbidity rate, that's the number of bone SREs or skeletal-related events per year, did go down with denosumab, as you can see here. And the adverse events really are kind of what you'd expect. The big ones with zoledronic acid have to do with a flu-like syndrome and achiness that people can get for up to a week. And it turns out we thought that was bad. It turns out it's good, because what it's doing is stimulating a kind of cell in your body called a gamma delta T cell, which is an anti-cancer fighting cell. And so in reality, we kind of like it. We're getting to the point now where we may even like that side effect that you get from it, the flu-like syndrome. But we're not sure. I mean, right now, a lot of us are trying to figure out, does the fact that you're getting that gamma delta T cell response with kind of that inflammatory reaction, is it really meaningful? Does it mean anything clinically? So what a lot of us are going back to do, we're telling, I'm a senior guy, I make the junior people do this. We're having junior people go back through records to see who got the bad side effect from the zoledronic acid, and did that correlate with a better outcome. It's a really interesting idea. But what you can see is that 27% of patients in this particular trial had an acute phase reaction versus only 10% with denosumab. And it's a typical thing you'd expect, the influenza illness, et cetera, flushing. The other thing is that if you give the zoledronic acid a little too fast, you get a little bit of insufficiency, just some irritation of your kidneys that's reversible. But the big one, I think, is osteonecrosis of the jaw. That happens in this case about probably 2% of the time, 1.4% with zoledronic acid, 2% with denosumab. We're going to get to something in a minute. We believe that it's probably due to the frequency of administration. And in fact, it involves an immune cell called an IL-17 secreting immune cell and in your jaw. And what happens is that it messes up the healing of your jaw, like periodontal disease, or if you get some sort of invasive procedure, it messes with it and it can't heal well. and it's probably due to a peak effect of the drug. And so if you're giving the drug every month, as opposed to every 3 or 4 months, or 3 months we're going to get to in a few minutes, maybe the incidence of ONJ will go down. And in fact, when we look at benign osteoporosis, or even people getting it for like early stage breast cancer every 6 months, the incidence of ONJ is pretty low. And it probably really has to do with the peak effect. It's like the amount you're getting plus every month, the frequency of getting it every month, that seem to be kind of the issues here. And again, in the question and answer session, I can talk a little bit more about that, because it is probably people's biggest question about these drugs. And it's kind of an interesting one and an important one to answer. So the question people always ask, and I'll go through this and I'll talk a little bit more about frequency, is how do we know that the bisphosphonates are working? How do we even know? That's a question we always get all the time. And it's interesting. So as I said before, bone is basically collagen with a bunch of calcium and hydroxyapatite surrounding it. And so as bone gets chewed up, what you have is called the NTX, the N-telopeptide of collagen. There's a piece of collagen at the end that gets chewed up and secreted into the blood, into the urine, and you can measure this. And levels of the N-telopeptide actually can tell you how revved up your bone is, and how close to fracture you are. Now the problem with this is that, the natural question to ask is, well, why don't we do this on everybody? It's great. The tests are very hard to do. The commercial test, it depends what time of day you do it, how much you eat that day, a lot of other factors, and they're not very reliable. So a lot of us, insurance doesn't like to pay for it for that reason, and a lot of us don't do it either. I mean, occasionally we will, but it's just for clinical trials in particular. But a lot of us don't really do it, and I think that, we'd like to, but it gets kind of difficult. Again, because you got to be very careful when you draw it in the same person. But anyway, given all those caveats, you can see here, if you have a higher N-telopeptide level, you have more skeletal complications, shorter time to a first skeletal complication, more progressive disease, and interestingly enough, more death. And so this is actually something we've been, this is not early, this has been around for 15 years. A guy, Rob Coleman, also a good friend and colleague of mine, who's in Sheffield, England, who actually recently retired, or is in the process of retiring. He's been very into this for many years. A guy named Alan Lipton also retired a couple of years ago at Hershey, Pennsylvania. These guys have been really into this. And I think that, we've wanted to use this, but the problem is that it's very difficult because, it's just so difficult to measure. But anyway, what you can do is you can see who did well with zoledronic acid, in survival. In fact, it looks to here, we always wanted to know, are these drugs making us live longer? Well, guess what? If your N-telopeptide is over 100 and you get Zometa, maybe you do live longer. Why that is very interesting. It could be because you don't get a bone fracture, you don't get complications from it, we don't know. But on the other hand, this is very fascinating data that's, probably 10 years old that a lot of us have thought a lot about trying to exploit. But again, the problem is trying to measure the N-telopeptide in per people. That's been the hard part. And, but this is kind of interesting. So what Alan Lipton did and his colleagues did in a very nice study that was published about 13 or 14 years ago is what they did is they said, okay, let's take women who have normal N-telopeptide, and, they don't do much. We'll see how well they do on zoledronic acid. Then let's take these people with elevated N-telopeptide, and either one of two things will happen. We'll give them zoledronic acid for a couple months, and either it will still be elevated or will go down. It was a very nice, clean experiment. And what happened is, gratifyingly, the vast majority of people, when put on these drugs, and this is not only breast cancer, but prostate cancer and lung cancer, most of them had their N-telopeptide go down. About 10 to 20% of breast cancer did not. And so what happened to these people? Well, if you were elevated and stayed elevated, you can see here, you had a higher risk of death as opposed to elevated or went to normal. In breast cancer, and that's pretty dramatic. In prostate and in lung cancer, it was the same thing. So that looked pretty interesting. And, I think that, this is, basically if it fell within 3 months, so this is telling you that there's something going on with these drugs to suppress somehow the osteoclast and stop that vicious cycle of everything going, from the osteoclast to the cancer to the osteoclast and back in the bone. There may be something here. In terms of skeletal complications, you can see here, if it was persistently elevated, you had almost everybody had an SRE within 18 months, whereas only half of the people had if they had a normal baseline or normalized, one that was elevated and normalized, you can see here, only about 60%. And again, the survival, as we showed before, was actually better. So again, we'd love to have these things. The problem is that it's difficult to do them. I think that a lot of us, now that I think we know a little bit more about what zoledronic acid is doing, we may start to do this again. The problem is that, zoledronic acid is generic, and as a result, a lot of the pharmaceutical companies are not as interested in pursuing this anymore, and it takes convincing the federal government, writing a grant, convincing the clinical trials groups to do it. So it's hard to know where we're going to go with this, but, I think it's interesting, and this sort of data kind of tells us, because we can tell you, everybody wants to know how well I'm going to do on the Zometa. I have bone mets, and I think that it's an interesting thing to think about going forward. So how often should we give these drugs? It's an interesting question. All of this with zoledronic acid, to be honest with you, was based on this one study, which is a couple people, that basically showed that the change in N-peptide with a single dose went down and then went back up with a month. So as a result, we started dosing everything monthly. That was how we decided on how to dose Zometa monthly, and I think a lot of us started to use the question. I'll go through this a little bit. We asked this question. It was a very good question, initially asked by Gabe Portabaji, who's actually still is to some degree the leader of the breast cancer program at MD Anderson. I think he also retired recently, or semi-retired. Gabe will never retire. He just loves doing this too much. But on the other hand, you can see here that what Gabe and his colleagues did, and this was presented many years ago at one of our ASCO meetings, at one of these ASCO meetings, what we did is that we took 412 people and actually they had already had zoledronic acid for about 9 or 10 months, and then we randomized them to receive zoledronic acid monthly or every 12 weeks, which was every 3 months. And in the study, you can see here, the N-peptide was kind of the same. It was a little bit higher, maybe, but not much. It pretty much was the same, whether you got it every week or every 3 weeks, maybe a touch higher. You can see here the urinary N-peptide on the left-hand side of this was a little bit higher. It was kind of interesting, but on the other hand, this is really the meat of the matter. There was really no difference in skeletal-related events between the 4-week and the 12-week, which I think was very gratifying to see in these women already on zoledronic acid. And you can see here, this just shows you the skeletal morbidity rate. The number of SREs per year was pretty much the same, 0.46 versus 0.50. But the most important thing, though, I think you got to look at is actually the amount of osteonecrosis of the jaw. That's on the right-hand side here. And you can see here there's 1% given every 4 and 0% given every 3 months. Consistent with the idea is that how frequent you get it, right around getting some invasive dental procedure or having some periodontal problem, that's when you get the ONJ. So if you're giving the drug less frequently, that's great. And so that means that, wow, this is like maybe we have a way of kind of reducing the ONJ, but still getting the benefit that you get of the drug. So there's another one. This is Charlie Shapiro, who at the time was at, I believe he was at Ohio State. He's now, I believe, at Montefiore Montefiore Hospital in New York. And I think that he and a group of people from the ECOG cooperative group did a very nice trial where they did this now on people when they first started. So these are not people just getting it. So you come in, you're newly diagnosed with metastatic disease, you have a bone metastasis, and what you see here is actually people getting the zoledronic acid every 12 weeks versus every 4 weeks initially. And again, same thing, typically the kind of patients we have, but showing you that the C-telopeptide, this is actually on the end, this is at the end of the molecule, not the beginning, was also a little bit more elevated on the every 12 week, and it wasn't suppressed as well. But on the other hand, what you can see here, and this is breast prostate myeloma, there was no difference in the amount of patients who had more than one skeletal-related event. It was about 25 here, 32 here, 23 here. And looking at this plot, absolutely no difference in skeletal-related events. In terms of time to event or the number of an event, you can see here, whether you give it Q12 or Q4, it made no difference. And I think this is yet another way. And so now the standard of care in women getting zoledronic acid is every 3 months and not every month. Denosumab is a little different. It's still given every month. And this, again, just shows you that the rate of osteonecrosis of the jaw fell by half. It was only 1% in the Q12 versus 2% in the Q4. And so as a result, that's pretty interesting. So there's less side effects with the same result, which we like to see in these sort of things. Now, the question people ask is, well, can we do this with denosumab? And there's this trial called REDUCE. It's an investigator in Switzerland who's doing this. We tried bringing this to the United States. There's a variety of reasons why we can. It's a trial in Switzerland. Trying to bring a trial from Switzerland to the US is hard for all the regulations, number one. And number two, a lot of health systems, ours included, really wanted to push everybody to use zoledronic acid every 3 months as opposed to denosumab monthly. So it's very hard to randomize people to this trial because of the request of all the payers and the health systems to go to the less expensive way of treating people. But anyway, it's being done the same thing. It's a really nice trial. They're accruing well, and hopefully have some answers at some point, whether we should be giving denosumab every month or every 3 months, consistent with the way we give Zometa. So I'm just going to end this with ONJ just for a minute or two, and then I think we'll stop. And I think, begin the question and answer period. I went a little bit over, but I think we're going to have about half an hour to talk. The bottom line is that ONJ is defined as exposed bone that has no evidence of healing. You can see this lower thing, you kind of see that. If you don't heal within 6 weeks of appropriate care, and you don't have evidence of metastatic disease to the jaw, that's the working definition for this. And I think that that's kind of what we do, and it's important. It's important to know that early recognition of this is important. It's all a learning curve. Oncologists, like everybody else, have a learning curve with these drugs. I, who give a lot of these agents, had a learning curve in 2002, 2003 with all of my colleagues when it started happening, and people who didn't know what it was. Over a period of time, we realized what was happening and basically told people, if you are getting an invasive, you can get your teeth cleaned. No one cares about that. If you are getting an invasive dental procedure, we like to hold whatever it is, be the denosumab, be the zoledronic acid, for a few weeks before and after, maybe a month before or after your invasive procedure. We also want people to really try to take care of their periodontal disease as best they can. We know people have periodontal disease, just a thing of getting older. We all get it, I'm sure. But the bottom line is we try to get people to just be aware of it. And when you do this is from Italy, the incidence goes from 3% in this study to 0.7%, a 77% reduction. So clearly with awareness and rapid kind of, thinking about it and treatment, we can reduce the incidence of fairly severe ONJ fairly quickly. So again, this is just the fact that people can be on this for a long time. This is our group for a number of years ago. We had 220 women on long-term, monthly Zometa. We don't do monthly anymore, but it used to be monthly. And most of them had had it for more than 24 months. And in this trial, we had an ONJ rate of 3.8%, a renal insufficiency, which rapidly improved at about 11%. It's interesting that 3 of the 6 patients who developed ONJ actually resumed it. And I think that if we were to study this now with the Q3 month data, we probably would have a lot less problems with ONJ now. So again, I'll summarize, and I'm going to give control of it back to Aaron. Estrogen receptor positive metastatic breast cancer, I want to be very clear with this, and we can talk a lot about this. This is just one topic of many, in what I've been doing in my life in breast cancer. But the bottom line is that it's a very slow-growing disease. We think, and we have a lot of drugs now that can keep it that way for many, many, many years, and so therefore, preventing complications like fractures are really important. Bone-targeted agents like zoledronic acid and denosumab can really help out a lot. Side effects like osteonecrosis of the jaw are uncommon, and with early recognition, I think are preventable. And so I'll leave everybody with that, and I'll open it to questions. And let me see, Aaron, how to give my screen back.
Thank you so much, Dr. Brufsky, for that really great presentation.
Yeah, hold on, let me just say something. I'm really sorry, guys, that I speak too fast. It's my nature. It's just the way I am. I really apologize. I sometimes get too enthusiastic about it. I'm willing to go over stuff with you more slowly, if you want. Plus it's recorded. And what I always tell people to do when they hear a recording of me, just turn it on slow, and they'll get everything. So I'm really, really sorry about that. So, let me know. I just saw some of the comments on the side. I just got a little bit going too fast.
Thank you so much. So one question we received was, what if there's any role for proton therapy with those living with bone metastasis?
So this, I'm assuming you're talking about proton beam therapy, which is a way of treating, it's a radiotherapeutic technique instead of the usual. So radiation is like protons. They're like these little kind of particles that they beam at stuff, versus an X-ray, which is a gamma ray, which is like a wavelength, kind of like a really strong radio wave. And I think that the difference between the two is that proton beam therapy theoretically can work just as well, but not have the side effects of radiation therapy to the bone. I think to make these proton beam machines is very, very expensive. They're called linear accelerators, and they're like $50–60 million. A lot of people don't have them. And the studies are all over the map. It's mostly used in prostate cancer because the idea is not to cause a lot of damage to the structures in your kind of around in your bladder in that area. In breast cancer, it's not used that much. And it's safe. I'm just not sure that it's not any more effective than the standard radiation we give.
Thank you for that explanation. We've gotten a couple questions about potentially over-the-counter products or ways to prevent or slow down osteoporosis or osteopenia. This person says, besides Zometa, this person submitting the question is using that drug, but is there any more advice about that? People looking for that?
I mean, there's bone loss. So there are two things going on. There's natural bone loss that Zometa also prevents, like female osteoporosis. There's tons of drugs that are oral, that are generic and inexpensive. There are also some over-the-counter things that people have, calcium, vitamin D, that sort of thing, that people use. That's different than kind of breaking the vicious cycle of a bone metastasis and a cancer cell kind of interacting with each other. And I think that that's a little bit different. That still does require, I think, some sort of bone-targeted agent right now. I don't know of any over-the-counter medicines that would interrupt it. I mean, some probably could. But I think that there's still a lot of generic, very inexpensive medicines that are oral. I mean, Fosamax, for example, that a lot of people know about. It's Zoledronic, Boniva, which is ibandronate. I think that there are ones out there that have been tested that do have some benefit if you don't want to take an intravenous or an expensive drug. But on the other hand, I don't know any over-the-counter things that can interrupt the bone cycle with the bone metastasis and the cancer cell.
Connected, someone also is asking sort of exercise or sort of the role of sort of bone strengthening. Or
so all of that's great. Again, you want to distinguish between osteoporosis, which is a general weakening of all your bone, as opposed to the weakening of the bone around a metastasis. For all of your bones, it's a great thing to get weight-bearing exercise. Absolutely fabulous. I think everybody recommends that with a good diet, a lot of calcium, vitamin D, etc. But I think, again, it's also fine to exercise when you have bone metastases. Just be careful, because some of those metastases could be in a weight-bearing bone, and you don't want it to fracture. Not to not want to go skiing, or I have patients with bone mets that go skiing and do all this other stuff. You just have to be careful, that's all. That just know you're going to have a few areas of your bone that may be weaker than other areas, and just kind of talk to your doctor and kind of work together to see what exercises I think are best for you, especially weight-bearing.
And would there be anyone else in the healthcare team you would recommend patients connect with around making decisions around safe exercise? Is it the medical oncologist? Is there a cancer specialist? Exercise?
Yeah, I mean, medical oncologists, nurses, nurse practitioners, physical therapists. A lot of people may go to physical therapy for some reason, for rehab. I think those, personal trainers, all these people work together. The key is communication. I mean, I get calls all the time for personal trainers. Can people do this? Can they do that? And, we talk about it. And I mean, I know the patient, I know where her specific metastases are. And I just say, okay, yeah, sure. I say, no, maybe we'll take a break on that one for a while. It's all about communication between all of the people of your team. That's really important.
We had a question about the trial you read. It was the Swiss trial looking at the
It's Prolia. It's denosumab every 3 months versus every month, right?
Thank you. Do you have an estimate of when we might get the results?
I don't. I think they accrued everybody. I think we're just waiting to see what happened. I have to email the PI. I haven't emailed them for a couple months. All of us, because I really literally wanted to bring that trial to Pittsburgh because I wanted to treat people. I believe it's going to work just as well. And on the other hand, we just don't know. And we want to know. I mean, hopefully we'll have some data within the next year. I'm guessing within the year.
There was a question about wondering if you could comment on oligometastatic bone mets.
Oligometastatic disease?
Yeah,
that's interesting.
So progression there.
Yeah, so, I'll tell you, there's a lot of people, us included at the University of Pittsburgh, that treat oligometastatic disease almost like a curable disease. I mean, people with 1 or 2 bone metastases do extraordinarily well. I mean, I have women in my practice, it's now 10, 12 years later, who come off their anti-hormonal therapy. I mean, it's like anybody else. I say, listen, Dr. Brufsky, I don't want to do this anymore. I don't do Zomed anymore. I don't want to do someone who's on Lupron shots or to suppress her ovaries. She said, I want to stop. And, and she has not had any progression. And we all have these people. It's not everybody. But oligometastatic disease, people can do well for a very, very long time. And I think that the question then becomes, should we be using bone-targeted agents in them with all the potential complications? And it's a real question. It's more an art of the medicine sort of thing. We kind of look at you, we kind of look at the Met, we kind of say, well, maybe we'll wait, see if more Mets. I mean, it's a real clinical judgment. You can't put that one into a box. And I think that, some of us give it Zometa up front for a single or 1 or 2 bone Mets, some of us don't. And I don't think there's any right or wrong answer, to be honest with you.
Thank you for that response. We've had a couple questions about dental procedures. One is asking you if you could review again your recommendation for invasive.
So what I tell people, it's very simple. What I tell people before they start this, to have a decent dental exam, be sure you see your dentist before you get going on it. Just to be sure, if you have any periodontal disease, it's dealt with, or you kind of know up front what's going to happen. But you can have your teeth cleaned. No one has a problem with that. What at least I have a problem with is an invasive dental procedure within a couple weeks of you getting the infusion. So say you need you need a root canal or you need a tooth extraction, and you're supposed to get your Xgeva or your Zometa like the next day or the next week. I'll tell you, look, get the dental procedure done. Let's just hold your bone target agent for about a month or two, and then we'll give it back to you. That's basically in a nutshell how I deal with it.
Great. Thank you for that clarification. We have a question: Is Zometa ever given with Zolota, or is it only with AIs?
All the time. We give Zoledronic acid. I saw, I think, on the chat, what about triple-negative breast cancer? It works just as well. As long as you have a bone met, it doesn't matter. It's given with chemo, hormonal therapy, trastuzumab, Herceptin, everything. We give these drugs with everything. And we've done that for years and years and years. And it doesn't interfere with the chemo or the hormonal therapy or whatever. So it doesn't matter. You got triple-negative breast cancer, ER-positive breast cancer, you're on an aromatase inhibitor, a CDK4/6 inhibitor, chemo, targeted agents, whatever. Clinical trials even allow most of these drugs to be given. So, you give them, they're just, it's like the baseline. You just get this no matter what, and then we layer things on top of it.
Great. Thank you. We have another question to just have a little bit more in depth or a different explanation. So is it possible to, so this person is looking for the difference, for you to explain the difference between zoledronic acid and denosumab.
Denosumab, Xgeva. So there's Zometa and Xgeva. So they both work on the same cell. So they work on the cell called the osteoclast that's responsible for chewing up bone. That's what it does. And so among many other things. But the big one is it chews up bone. And both of them try to reduce the amount of osteoclast in your bone to let your bone heal and not get chewed up. So the way Zometa works, or zoledronic acid, it's this little small molecule that looks kind of like calcium in a way, that the osteoclast takes up and it kills it. That's how it works. Denosumab works by binding a specific receptor on the osteoclast. It's called rank, R-A-N-K. It binds to the rank and blocks it from basically interacting with other things that bind to it. And so that's how, and it also kills the osteoclast in that way. So they both work on the osteoclast, but just in a different way. It's the best way to describe it.
Can you discuss lytic versus stereolytic lesions?
So lytic lesions are the ones osteoclasts are mostly responsible for that. So like myeloma is almost all lytic. All the solid tumors like bone and prostate and lung that have things, they're mixed. So they're lytic, but they're also blastic. So in other words, blastic means you've got a lot of the osteoblasts and they're trying to make bone. Most bone lesions basically are a combo of both because the tumor cells are secreting things that stimulate growth, that stimulate destruction. And so that's basically what we're talking about. So, you want some degree of lytic bone lesion to expect benefit from Zometa and Xgeva. But the thing is that, we thought forever that prostate was almost always blastic, for example. I know you guys are not prostate cancer survivors. But the thing is that we now know that all lesions, basically from solid tumors, are both lytic and blastic. And so really what the Zometa really does is deals with the blastic, the lytic part of it, I'm sorry.
So a question around the zoledronic acid and whether it's ever been looked at giving it once a year, since the dosing and the timing is so...
Absolutely. So for benign female osteoporosis, okay, it's given once a year. It's called Reclast. It just has a different name. It's given 5 milligrams instead of 4, and they call it Reclast. People who have benign osteoporosis get it all the time. So for people who have early stage breast cancer, not the kind, not metastatic, it's being every 6 months. So we give it every 6 months. And we call it Reclast. We also call it, Zometa. Same thing with Xgeva. So Xgeva is the once a month dose. Prolia, which is the same thing, is once a year. Again, for benign female osteoporosis, once a year is okay. For women with breast cancer, like on aromatase inhibitors who have osteoporosis, every 6 months is okay. Again, we don't know, we had this huge debate. It's a great debate. We don't know whether giving it once a year is as good as giving it once every 3 months. And I think that, to me, is a big question. Again, it's going to be hard to answer because no one, you got to get the company or the government interested in it. There's only so many things that can do at once. And so, I think that we're never going to know the answer to that. But I think it's a great question. Could you be just getting one Zometa a year for your bone metastases and will it be enough? We just don't know the answer to that.
We have a question asking how long someone should stay on Zometa. This person's experience was their doctor was recommending no longer than 5 years.
Yeah.
Is there guidance there?
Great question. And I think it's one that, thankfully we have, because everybody, a lot of people now who have metastatic breast cancer are living longer, 5 years or longer. That's a good problem to have, guys. That's what I'm really be very careful to say that. I think that it's an interesting question. What tends to happen if you give it longer than 5 years, you get something called atypical femoral fracture, that your bones of your femur, which is right around your hip, become kind of weak, and you can spontaneously fracture them. I've had a few people who've been on these drugs for 10 years or more, and I've had a couple that have had this. And again, who gets it, why they get it, we just don't know. So after 5 years, we tend to use a lot of caution. One thing that we do is a lot of us, after 2 or 3 years of this, go to every 3 months. Now with Zometa, it's every 3 months. With denosumab, though, the recommendation is monthly, but I think a lot of us kind of informally, while we're still waiting for that SAKK trial, have been kind of doing this on our own anyway. As I think a few people in the comments have answered that.
Mm-hmm. Great. Thank you for that further clarification. A question about diagnostic testing and monitoring for bone metastasis. What's the recommendation there? This person's saying CT, PET scan, nuclear medicine.
I'm okay. I'm okay with a PET CT or a CT. I think for me, what I'm kind of moving away from is bone scans, because sometimes what will happen, this is really important for people to know, that you start a therapy and you have bone mets. A lot of times in the first 3 months, the bone mets flare, and they look at worse on CT scan. And I've had consults. They don't happen as much as they used to, but I used to get consults because I do a lot of second opinions and stuff. And I have had people come to me who have had the doctor goes, oh my gosh, I put you on this drug and now your bone mets look worse, and it's 2 or 3 months later. And I said, well, wait a minute, that's not the case. It's a flare. Let's give this a few more months and it'll go away. And for that reason, I've moved a little bit away from bone scans for that reason. I tend to do PET CTs when I can, because PET CTs gives you both. It gives you also the visceral disease, like in your lungs and liver and elsewhere, as well as disease in your bone at the same time. So if available, the problem is that PET CTs are often not paid for by insurance, like regular CTs. So we kind of have to sometimes go to regular CTs and look to see if there are more metastases in those areas. Someone mentioned something called sclerotic lesion. That's actually a treated bone lesion. So in other words, they'll comment, they'll say, oh, there's a sclerotic lesion here. And what that means is that it becomes filled in. So it becomes really dense looking and filled in. That means that it's been treated. It's a treated bone metastasis, which is a good thing to have, actually. The problem is I always tell people is that on a CT or bone scan, you're never going to get rid of all of the bone abnormality. It's always going to look either it's getting worse or getting better. It still looks weird on the scans. And so, we got to kind of put the whole picture of you together, your symptoms, the scans. Some people do tumor markers. I personally do a CA2729. We put it all together, and if everything's going in the same direction, then we'll make a decision based on it, either leave you on your therapy or change. But that's what a lot of us do. It's kind of almost like an art of medicine, an art of oncology.
We have a question about managing pain associated with
Sure.
bone metastasis. How's it typically managed? What is your recommendation?
Yeah, it really depends on the kind of pain you have. I think, in this whole opioid crisis stuff, I think cancer patients are kind of out of that in a way. It's just, you got cancer pain. And in my experience, cancer pain almost never leads to addiction to an opioid. That's just been my experience having done this for 25 years. But again, we're all cognizant of this. It's something that's important, the opioid crisis. And so kind of what we do is we try to start with non-opioid interventions. So, either kind of, anti-inflammatory drugs, maybe some corticosteroids if we can get away with it, radiation if we can get away with it. But clearly, if you need opioid pain medicine, we start with low things like Tylenol number 3, Tylenol with codeine, and then gradually escalate it as you need it. I usually escalate people to oxycodone and OxyContin if I have to, Percocet first, then long-acting OxyContin. If you have to go further, then we do Dilaudid and MS-Contin and morphine. So that's kind of how I do it. I try to escalate it, but what we all do, at least some of the big practices like mine, we have all pain specialists that manage this now. We've just learned that over the years that it's just better to have one person that you go to, that you're not getting opioids or whatever pain medicines from 5 or 6 different people. And in fact, in Pennsylvania, they actually have, I'm sure other states do this too, they have a requirement. They have this whole thing now, it's on the internet. You have to register every time you give somebody an opioid. And so, you can't give too much of it. And so we've just found that if there's multiple doctors involved, that it's really confusing. So we tend to try to have only one person be the person that prescribes the pain medicine. That's all the things I just said to you. I think that's, when you go back to your docs, there should really only be one person that's doing it. It could be your oncologist, it could be your pain specialist, your PCP, whoever. I think that it's really important to just have one person manage this of everybody.
Thank you for that advice. So a question about osteonecrosis of the jaw. What if someone does develop that condition? What are the options for treatment after that?
So generally, with the eye, again, what we like to do, if you can, and again, I have my patients and I were fortunate that we're in a big medical center, so we have access to oral surgeons one of whom actually has been working with us for about 10 years. The thing is that you really should have an evaluation. That's number one. You got to stop whatever bone targeted agent you're on, have an evaluation. And generally what they do is antibiotics and mouthwashes for a couple weeks to see if it can get better. And that's generally, it's like topical stuff plus maybe oral antibiotics. And they try to heal it that way. Very, very, very rarely do they have to scrape the bone out or do some sort of surgery. Sometimes they'll have to take a piece of dead bone off and let it try to heal openly. But generally that's the theory. I mean, most people will probably get better with oral antibiotics and mouthwash rinses, antibiotic rinses, with stopping obviously the bone targeted agent also. That's generally tend to like how we treat it. It's not optimal, but it's the best we have right now.
Okay. And a connected question. So someone was sharing that they were on Zometa and then switched to Exiva and then received the diagnosis of the osteocrosis of the jaw. Right. So would it be safe to go back? Is that, or
it's a great question. The answer is probably no. I mean, I don't know. It depends on if you're getting it monthly, every 3 months. It's an interesting question. One thing I may consider, it depends on how many bone mets you have, how many complications you've had. It's not an easy question to answer. I have, in consultation with oral surgeons, restarted people on Zometa. Like in that trial, 3 of the 6 people in that trial that I showed you restarted. And so the thing is that I have done it. I think, it all depends. You have 1 or 2, if you have oligometastatic disease, you haven't had a lot of pain, everything's under control, I probably would say hold it. If you've got tons of bone nets, and you're still having pain, I probably would think about the latter, maybe cautiously restarting it. I think it's really individualized. It's very hard to make one comment up for everybody.
Yeah, that makes sense. Thank you so much. So I have some couple questions about treatment options or other treatment strategies. So one person is asking if there's any role in cyberknife therapies or for treating bone mets.
All the time. We do it all the time. And the nice thing about cyberknife, the nice thing about cyberknife, you can do it multiple times. And you can do it after whole area radiation. We do it in the brain all the time, because it doesn't hurt the surrounding brain tissue. And I think it's really great that you can give it. We give it multiple times. There's that. There are what are called radionuclides. One of them is called samarium or quadramet. That's like a really, really radioactive bone scan. It can go to multiple areas of your body and radiate them over a short distance or release pain quite dramatically. And I think that, there's that. So there are other modalities. Besides, even some people have thought about using radio frequency, where they stick a radio frequency probe into it like a microwave and microwave the bone met. Some people have done that as well. Again, all of those are kind of like, the samarium is around, the cyberknife we do all the time for bone mets. The radiofrequency ablation is very limited. And, again, that's still kind of, not quite in clinical trials, but a lot of us, don't really use it that frequently in our practices.
We have a general question about any dietary recommendations for those that are have bone metastasis. Anything?
No, I think the big ones are you need adequate calcium, adequate vitamin D. I think those are the big ones that we tell people to do. Really, other than that, I think generally docs. Look, for metastatic disease, I'm the kind of doc that wants you to eat crap. I want you to get lots of calories. Okay, and the reason for that is if you're losing weight, I don't want people to lose weight. If you're not losing weight, eat a really nice, healthy diet. It works for everything, not only cancer. But if you're losing weight because of your cancer, I don't stand on ceremony. Eat a pie, eat ice cream, I don't care. You need the caloric intake. Okay, I know that's kind of like blasphemous for a doc to tell that to you. But on the other hand, I think it's really, really important to maintain a caloric intake if you're losing weight. Now, not everybody does that. If the vast majority of people who don't lose weight from their cancer, then a healthy diet is the way to go with a lot of calcium, a lot of vitamin D. I think for bone health in particular, that's pretty important.
Great. And could you talk a little bit more about the dosing, that potential for vitamin D or calcium, and is that?
Yeah, it's all over the map. I mean, I think that, it's all over the map. I mean, I don't think 1,200 is probably too much. I mean, probably 400, 800 of calcium a day, and maybe 2,000 units of D or something like that. I mean, it really depends on where your D. I mean, what I would do in most people is have your D level checked. I think that's important, because a lot of people are D deficient in the U.S. and don't realize it. And I think to correct, and it turns out it's really interesting that if we correct someone's D, a lot of people get arthralgias from aromatase inhibitors. I mean, those of you who are on the line probably get it. Some of you probably have gotten it. And the issue is interesting that when we correct people's vitamin D, someone wrote an abstract about this a while ago at one of our meetings, that actually the incidence of arthralgias goes down. So it's interesting. I mean, who knows if it's real or not? It was like one abstract. I don't think there's anybody ever seen it in publication yet. But on the other hand, it's kind of interesting that maybe you need your D corrected. And I think just getting your D measured is really important. What the level is important. Some people think it's 30, some people think it's 50. I mean, I think if your D's over 30, I think you're fine. I think most people are okay.
Great. Thank you for that clarification. We've had a couple follow-up questions about the CyberKnife procedures.
Sure.
One is what is the side effects of that procedure, and then when is that not recommended, or kind of when is it recommended for that and not?
To be honest with you, usually, let me tell you how we do radiations. Let's start with that. So you develop a bone metastasis. It used to be that we give you 10 treatments of what's called 300 centigrade, or rads. So each treatment would be 300 rads. You get 3,000 over 2.5 weeks. That used to be the recommendation. Then radiotherapists realized they can give 5 treatments. So of the same 300 a day, so 1,500 centigrade. They can give 5 treatments of external radiation, where you sit in the machine, they have a beam go at you. And then they realized they could do 1 treatment of 800 centigrade. A single treatment, a single fraction works just as well. A big trial proved that, I don't know, about 4 or 5 years ago. And so now the radiation therapist will always really want to go to 1 fraction. The nice thing about that is that the surrounding tissue can only get so much radiation, about 3,000 or 4,000 centigrade total. So, if you give 800, you can only give it a couple times. Now, the nice thing about CyberKnife is that it's even more focused than that. They really use a CT scanner, and they make this very precise, what's called a contour map, right around the metastasis, and radiate it in a single dose. You have to stay stable. They put you in a frame. They got to make you stay stable for it, because it's a little bit higher. It's like 1,500 centigrade. It's a little bit higher than 800. So there really are very few contraindications to it. I mean, sometimes if you've been radiated multiple times, you've had 3 or 4 CyberKnives in the same place, they may not want to do it anymore. The tolerance of surrounding tissue, for example, if it's to a vertebral body, the spinal cord's right there, so they're going to be very, very careful that you don't cause radiation damage to the spinal cord. So, again, that's one of those one size contraindications doesn't fit all. It's really going to depend on kind of what you've had already, kind of where the metastasis is, what the surrounding structures are.
So a question about vertebrae compression fractures,
Sure.
And kind of what are the best interventions for that?
So I'll tell you, it's a lot. I'll tell you one intervention we like. It's had an interesting history. Is something called kyphoplasty. And for a compression fracture of the vertebral body, what a lot of people have tried doing is what they do is, so here's your spine right here. They stick a needle in it, and that needle has cement in it. It has a balloon in it, and they blow up the balloon, which blows up your vertebral body. Then they insert cement into it, and it relieves the pain quite dramatically when it works. And it works a lot of the time. And a lot of people have thought of doing that for metastatic bone disease and vertebral fractures from it. Now, short of that, if you can't do that, we obviously do radiation, a brace, try to get you healing that way. And other systemic therapy, like changing your hormone therapy around, it could be chemo or something like that. But basically, that's kind of how we treat compression fractures. I like the kyphoplasty. If someone's pain is predominantly from a compression fracture, I will try to get them a kyphoplasty if I can. I'm in a major medical center. I have access to all these interventional radiologists. You may be in parts of the country where that access is a little bit more limited, but it's something to continue. If you have a compression fracture from metastatic disease, it's something to ask your oncologist about. They may know somebody.
So we have a question, CA 15.3 versus CA 29-20.
Yeah.
27-29. These hopefully are things that maybe you can
make a lot of sense. So CA 15.3 and CA 27-29 are both antibodies. They are to the same exact protein. It's the same protein, just a different antibody. They measure the exact same thing. It's circulating amounts of this protein that are secreted by your cancer cells that tells you how active your cancer is. About 2/3 of the time, women with metastatic breast cancer will have elevated levels. And when I tell people it's not the exact number, it's the trend. Does it go up a lot, a little? These are going to be variable. But if something doubles or triples or something like that, that's when I get a little bit more concerned. And it doesn't matter if it's the C 2729 or the 15-3. If it comes to go down with your therapy, to me, it means your therapy is working. A lot of docs don't use these because they don't believe they work. I personally think they do. But again, that's a physician-to-physician thing. There's still a lot of controversy about it. And I guess if your doc doesn't want to do it, I get it. If they want to do it, I get it. I personally like to do it.
Great.
So for me, I do.
And is there any difference for those with bone metastasis with that decision? Any unique aspects with this?
No, the nice thing, though, is the thing that I like to use them for is in women with bone metastases, because it's oftentimes hard to know. Are you getting better? Are you getting worse? We don't know because the scans look the same way. So 2/3 of the time it'll be elevated, and I'll use that number to help me with the bone scan or the CT or whatever to let me know whether someone's getting better or worse. That's kind of how I do it.
Okay, great. Thank you so much. And we are getting very close to the top of the hour. So thank you all. And thank you, Dr. Brufsky, for your great presentation.